Thank you for joining us for this webinar on vaccination and vaccine-preventable childhood diseases, data and trends. I'm very pleased to introduce today's speakers. We have Beth Jaros, who's a research associate here at PRB. She's going to start by presenting trends in vaccination coverage and vaccine-preventable childhood diseases for the major world regions. Her presentation will be followed by Reagan Faust, who's Senior Manager for Data and Research at the Lucile Packard Foundation for Children's Health. And Reagan's going to highlight some data for California and provide a brief demonstration of their kidsdata.org website. That presentation will be followed by Reshma Nayak, who's a Senior Policy Analyst at PRB, and she's going to wrap up by setting the policy context. Today's webinar is co-hosted by the Population Reference Bureau and the Lucile Packard Foundation for Children's Health. And with that, I'm going to go ahead and turn it over to Beth.
Thank you, Mark. What we're going to cover today are a series of topics, starting specifically with why vaccine-preventable childhood diseases remain an important public health concern. Then I'll talk about trends and disparities in vaccination coverage, both globally in the United States, and then we'll dive down into the local data specifically for California, and then wrap up with challenges and solutions to improving vaccination coverage worldwide. The U.S. Centers for Disease Control and Prevention define vaccine-preventable childhood diseases to include the 15 diseases shown on the screen. Unfortunately, data are not available globally for all 15. To ensure that we're using comparable data for all areas, much of our analysis today focuses on 4 diseases: measles, diphtheria, pertussis, and tetanus, in the 2 vaccines that cover those 4 diseases. We refer to those 2 vaccines using generalized acronyms. MCV means any measles-containing vaccine. For example, the MMR vaccine for measles, mumps, and rubella is a measles-containing vaccine. DTP means any combination vaccine for diphtheria, tetanus, and pertussis. The DTaP vaccine and the Tdap vaccines are examples of DTP-type vaccines. In a few charts, we use a vaccine acronym in combination with a number. The number reflects the number of doses for the target population. So for example, when I talk about DTP3 coverage, I mean the target population has received at least 3 doses of a combination diphtheria, tetanus, and pertussis vaccination. One of the challenges often presented against vaccination is the notion that vaccine-preventable diseases are no longer really a threat. Thanks to better nutrition and better treatment, the case fatality rate for measles in the U.S., for example, dropped from 25 deaths per 1,000 cases about a century ago to 3 or fewer deaths per 1,000 cases today. But that success story masks the truth that vaccine-preventable childhood diseases remain a common cause of death worldwide. Earlier this year, The Lancet published mortality estimates by cause of death for children and for the population as a whole. The chart on the screen here shows some of those primary causes of death for children under age 5. If we highlight the vaccine-preventable causes, we see that pneumococcal pneumonia is a more common cause of death than injury. Rotavirus, Hib, and measles are each responsible for more child deaths worldwide than drowning, car accidents, or HIV/AIDS. And pertussis and tetanus cause more deaths than SIDS. And when we group those 6 highlighted vaccine-preventable causes of death, pneumonia, rotavirus, Hib, measles, pertussis, tetanus, and influenza, into one common vaccine-preventable death cause, we find that vaccine-preventable diseases account for more child deaths worldwide than birth defects, diarrhea, injury, drowning, HIV/AIDS, or SIDS. And even when diseases are not fatal, vaccine-preventable diseases can cause discomfort, disfigurement, and disability. Measles, for example, remains a common cause of blindness in developing countries. The chart on the screen shows the number of cases of 7 selected diseases worldwide from 1999 to the present. The good news is that the number of cases has fallen to about half of its 1999 level. You may also notice, for example, that polio barely shows up on the chart. There's a faint black line that you can see in the early 2000s and in the mid-2000s. Polio fell from more than 30,000 cases per year in the 1980s to 7,000 cases in 1999 to fewer than 500 cases per year in 2012 and 2013. And preliminary estimates suggest that there were fewer than 500 cases again in 2014 as well. Thanks to vaccination efforts, only 3 countries still have endemic polio virus: Afghanistan, Pakistan, and Nigeria. And the other good news is that while confirmation is still pending, Nigeria may just have become polio-free this month. The bad news in this chart is that there are still more than 1 million cases of vaccine-preventable childhood disease worldwide each year. Of course, those case counts reflect trends both in incidence rates and a growing global population. If we look just at the incidence rates, we see some substantial improvements since the 1990s. If we follow the orange line on the screen, we see that there were more than 25 cases of measles per 100,000 population worldwide each year in the early 1990s. This fell to fewer than 5 cases per 100,000 population in the mid-2000s, but appears to have plateaued at that level. Diphtheria and tetanus, which you see toward the bottom of the chart, those rates are much lower, but their case fatality rate is substantially higher than for measles or pertussis. And last, but certainly not least, pertussis, the plateau is even more important. The rate has hovered at about the same level since the mid-1990s. An important reason for this stall in the rates is that vaccination coverage appears to have stalled as well. Now I'm going to move from our PowerPoint slides to an interactive graphic on the PRB website. If you go to the article Progress Stalled on Vaccine-Preventable Diseases, about halfway down the page we have an interactive graphic where we have the vaccination coverage rates for DTP3 and measles from 1980 to 2013. And as you can see, the world has made great progress since 1980. Worldwide, 3-dose DTP coverage was only 20%. By 1985, it had grown to 50%. In the 90s, it was in the 70% range. But as you can see, in the last 5 years, there's basically been no improvement at all, with DTP3 coverage hovering at about 84%. We see similar trends if we look at 1-dose measles vaccination coverage. Again, basically no improvement in coverage rates worldwide over the last 5 years. On the screen, you can also see variation by world region. The regions shown are the United Nations Millennium Development Goal regions, and there's a wide variation in vaccine coverage across and between world regions. So the highest coverage rates, shown in the darkest blue, both for 1-dose measles containing vaccine and 3 doses of DTP, are 90% or higher in the Caucasus and Central Asia, countries like Kazakhstan and Uzbekistan, in Eastern Asia, countries like China and Mongolia, and in Northern Africa, countries like Egypt and Morocco. In the lowest levels, both for 1-dose measles and 3 doses of DTP coverage, where coverage is below 75%, occur in sub-Saharan Africa, countries like Nigeria and Somalia, and in Oceania, countries like the Marshall Islands and Papua New Guinea. I should be clear that not all countries with within high coverage regions have high coverage, and not all countries in low coverage regions have low coverage. For example, Rwanda and Uganda are in the low coverage sub-Saharan Africa region, but both countries have MCV and DTP3 coverage of 97% or higher. Disparities within countries are also important. In 2013, 2/3 of countries achieved the global target of 90% DTP3 coverage, but national rates tell only part of the story. In the same year, more than 70% of countries failed to achieve 80% coverage in every district or equivalent administrative unit. In other words, in 7 out of 10 countries, there are pockets of extremely low vaccination coverage. Part of the reason for those pockets of low coverage is that effective delivery of vaccines remains a problem, particularly in remote, impoverished, or strife-torn areas that are difficult to reach due to geography, weak or non-existent health systems, or other structural barriers like nomadic populations, language, and literacy gaps. And this is not merely a developing nation problem. We see local variation within the United States as well. In the US, those variations are largely the result of vaccination policies, which vary from state to state. The map you see on the screen here shows data from the National Immunization Survey for 1-dose measles vaccination coverage, or MMR coverage, for children aged 19 to 35 months. And as we can see, 17 states have MMR coverage of below 90%, shown in the orange colors on the screen. The lowest rate is in Colorado, in the darkest orange, where only 86% of children aged 19 months to 35 months have received at least 1 dose of the MMR vaccine. And dark blue shows areas that have the highest coverage, and the highest state is New Hampshire with 96% coverage. We see even more variation when we look at 4-dose DTP coverage. You can really see the stark differences there in terms of coverage rates. Many, many more states have less than 80% DTP 4-dose coverage, and only 5 states exceed 90% 4-dose DTP coverage for young children. The highest rate of coverage is in Massachusetts with 93%. The lowest is in Arkansas with 74%. And just to add some context for other U.S. territories that are not shown on the map, in Guam, the level is about 72%. In the U.S. Virgin Islands, coverage for young children is about 51%. And while there are no data for Puerto Rico reported in the National Immunization Survey, there are data from a separate kindergarten survey, and their coverage is about 91%. Part of the reason why we see such variation by state is that policies about vaccines vary from state to state. All states have recommended vaccination schedules for children, but the type and number of vaccines required varies from state to state. And all states require that children provide proof of immunization before enrolling in school. But again, those requirements vary. Some states may require 4 doses of DTP, some require 5, some may require varicella vaccination, some may not. In addition to differences in the recommended schedule of vaccinations, states have differences in what types of exemptions they allow to those school enrollment policies. All states allow medical exemptions to school enrollment vaccination requirements. In other words, there are some children who have weakened immune systems, allergies, or other medical reasons for being unable to receive vaccinations. These medically necessary exemptions are allowed in every U.S. state. And as you'll see when Reagan Faust shows the data for California exemptions, medical exemptions are actually fairly rare. Less than 1% of kindergartners qualify for a medical exemption in most states, and in fact, in many states, less than 1/2 of 1% of kindergarten-age children qualify. Some states also allow religious exemptions, meaning that a child may enroll in school without vaccinations if the child's family has a religious objection to vaccination. And some states also allow personal belief exemptions, meaning if a parent believes vaccines are harmful or that they're not effective, if a parent does not trust the government, if a parent has other reasons for not getting a child vaccinated, the parent can sign an exemption waiver form and the child can enroll in school without vaccination. And as you might imagine, states that have generous personal belief exemption policies tend to have lower vaccination rates overall. And here, Reagan will talk a little bit more about the data for vaccination exemptions in California.
Thanks, Beth. I'm thrilled to represent the Lucile Packard Foundation for Children's Health, and we're an organization that's dedicated to elevating the priority of children's health in California. And to that end, we operate kidsdata.org, as you can see on the screen. It's an easy-to-use resource that offers high-quality, wide-ranging, and local data about the health and well-being of children with an emphasis on California. So the site itself offers most recent data available from more than 35 credible public sources on more than 60 important topics, including immunizations. And so let's just dive in so we can explore the data for California. In order to access the data, if we're interested in immunizations, we can just type in immunizations into the search bar. And this will provide a list of indicators available as well as summary information for this topic. So in this topic, Kids Data provides a wide variety of data, including the number and percentage of kindergartners with all required immunizations and those with immunization exemptions for the 2014 and 2015 school year, and this is provided for every county and school district in California. And in addition, you can find an indicator unique to kidsdata.org, and this is the incidence of vaccine-preventable childhood diseases, including pertussis, measles, and mumps in each county in California. And this is thanks to a data partnership with PRB. We also provide helpful narrative contextual information down below at each topic level in order to help you make sense of the data, and also curated lists of freely accessible research and links to round out your understanding of each issue. So what does the data tell us about immunizations in California? Let's dive into kindergartners with all required immunizations. So the data shows that in the 2014-2015 school year, 9 out of 10 California kindergartners, and that's 90.4%, received all state-required immunizations by the time that they entered school. And this is slightly down from 2005, when 93% of kindergartners had all required immunizations. You can see the slight downward trend. Among counties with available data in 2015, the percentages ranged widely at the county level, from 72.6% all the way to 100% in some of these more central California counties. And as Beth mentioned, some children are exempt from immunizations. So let's dive into that data set. In 2015, you can see that 2.5% of California kindergartners were exempt due to their parents' personal beliefs, and only 0.2% actually had a permanent medical exemption. This is an exemption for medical reasons. 6.9% were due to other reasons, and you can always find the reasons why down below in the definition, data source, and footnote. Okay, and looking at the map, the percentage of children with personal beliefs exemptions in 2015 also ranged very widely at the county level. So we have, some counties with no data, others with less than 1% of the kindergartners receiving personal belief exemptions. But we also had counties with as high as 21.5% of all children attending public schools in those counties were exempt from immunizations due to parental personal beliefs. So now let's explore the incidence of vaccine-preventable diseases, and specifically pertussis, as that alone accounts for the majority of all vaccine-preventable diseases diagnosed. So we can also enter data this way. In 2014, the number of cases of pertussis peaked in California, as you can see from this trend. In that year, 11,203 cases of pertussis were diagnosed, and this actually accounted for 39% of all of the cases in the United States that year. If we would like to see this as a rate, this changes our understanding as well. So California 2014 pertussis rate, which is 29.3 people per 100,000 people in California. This was more than 3 times the rate nationwide, which was 9 of every 100,000 people. So you could see California is bearing a disproportionate burden for pertussis, especially in the most recent year of data available, which is 2014. There was also striking variation at the county level, with rates per 100,000 ranging from 0.0 to more than 100 in some of these Northern California counties. So now that the personal belief exemptions have been eliminated in California, we're all very interested to see how these figures are going to change. So if you'd like to be notified automatically when the data are updated, or to receive advisories on data related to child health and well-being, you can actually just enter your email into this box, and we will send you an email so you can be notified to explore the new data. And now that we've explored this vaccination coverage in California, I'm going to turn it back over to Beth and Reshma to explore some challenges to increasing it domestically and worldwide.
All right. Well, so far we've talked quite a bit about the state of affairs when it comes to vaccination coverage, both in the U.S. and in other settings. So now what I'd like to do is move into a brief discussion about where some of the key challenges lie and how we might overcome them. So if we start with the challenges on the supply side for vaccines, we can see in the upper left-hand corner that one key challenge is accurate forecasting and stock management. So when forecasting is done poorly, it can lead to gaps between supply and demand. such that underestimates might mean that not all children who are brought for vaccinations actually receive them. But meanwhile, it's important to realize that overestimates can also be a problem, as overestimates can lead to excess stock, which drive up manufacturers' costs, and then these can be passed down the chain to those who procure them, which can create a different type of access barrier. Then next, if we move to the two adjacent boxes, where we're looking at the infrastructure for delivery and the cold chain, there are also a number of challenges there. In many low-income settings in particular, the infrastructure for delivery might be weak. And this could even relate to such basics as poor roads or even limited availability of vehicles and fuel for transport. And then, of course, we add to that the fact that vaccines require a cold chain, which is a process to maintain optimal temperatures from the point of manufacturing to the point of use. And in many places, this cold chain can be inadequate, especially where there's limited or poorly maintained equipment, such as freezers, refrigerators, generators, and also in places where the electricity is unreliable, where there are extreme temperatures, or also where vaccines need to reach distant populations. And then finally, the cost of vaccines themselves can still be prohibitive in many countries, especially in the face of competing priorities. So this graph here is from a commentary that was published last year in the journal called Global Health, Science, and Practice. And this commentary highlighted the fact that the cost of the recommended full schedule of vaccines in the developing world has risen from about 57 cents per child in 2001 for a set of 6 vaccines to more than $21 per child in 2014 for a set of 11 vaccines, because the recommended schedule has been increased over time. And then, as you can see here in the graph, adding HPV for girls would increase the cost substantially. So we should also keep in mind that challenges to vaccine coverage are not all related to supply and delivery. So I do want to take a minute to mention a few of the issues that can pose a challenge on the demand side. I'm sure it's clear to most of us here that the success of any vaccine program is dependent on parents' beliefs in the effectiveness and the safety of vaccines. However, across the world, from the US to Nigeria, some parents do lack accurate knowledge about vaccines or continue to harbor concerns about them. And studies have shown us that these parental attitudes can pose important barriers to vaccination. And in some settings, particularly in the US, these negative parental beliefs and attitudes can also sort of intersect with more structural factors, such as school immunization policies, which we've talked about at length already. So for example, where policies are more lax, parents with negative attitudes may have an easier time skipping out on vaccinations for their children. And then finally, it's important to keep in mind that the nature of exposure to the healthcare system can also have an effect on parents' attitudes towards vaccines. Limited knowledge in some cases might be due to limited exposure to the healthcare system in general. For example, there was a study in Pakistan which showed that vaccination rates were lower among children whose mothers did not use health services such as antenatal care or delivery. But it's also important to keep in mind that even when people are exposed to the healthcare system, if they have notably poor experiences, even in relation to other health issues, this could lead parents to have negative perceptions or doubts about things like vaccine quality or even their availability. So now let's move on from the challenges to the way forward. The Global Vaccine Action Plan lays out a broad roadmap for achieving immunization goals. And this plan includes 6 guiding principles, which include country ownership, shared responsibility and partnership, equity, integration, sustainability, and innovation. So keeping in mind these sort of broader, more lofty principles as a foundation, there are actually also some more concrete activities that can help us overcome some of the key challenges. So I just want to go through a few examples of those. So first, there are existing tools that can help improve forecasting and stock management. So more training and capacity building to use these tools can actually go a long way to ensure that vaccine supply and demand are adequately matched. And it's important to also keep in mind that it's not only about the forecasting, but also ensuring that we put in place the mechanisms for the timely release of sufficient financial resources that also match the forecasting needs or the forecasted needs. Secondly, we can build upon the capacity of our health personnel for effective management and supervision. Interestingly, I read recently that, although the skills that are needed to implement effective vaccine programs have increased over the years as the recommended schedule has expanded, we've actually been using the same basic approach to training for over 30 years. So some potential new approaches that could be used include e-health or mHealth technologies, or even incorporating this into pre-service training so that people are sort of well entrenched in the issues and understanding of it before they even enter their jobs in the healthcare field. Then to address some of the structural issues when it comes to vaccine delivery, there are a number of different innovations that have either already been developed or are in progress, and these can be further tested in specific settings and potentially scaled up. So for example, there are improved cooling and insulation materials, temperature monitoring devices, solar-powered refrigeration, and then also other modifications that can be made to food storage refrigerators, that are often used for vaccination storage both in the U.S. and in other countries. But oftentimes these refrigerators are not up to the World Health Organization standards for the purpose of vaccine storage. And then finally, it's important to keep in mind that when we want to address the demand side challenges in terms of parental attitudes and beliefs, it's going to be very important to ensure that all vaccine programs dedicate enough time and resources to effectively communicating and building partnerships with the communities that they serve, with the intent of building a greater degree of trust and understanding between parents and the healthcare system. So before we move into the Q&A session, we just want to remind you that you can find further information on this topic in 2 web articles that are posted on the PRB website. Both of these articles provide references for the data that we've mentioned in our presentation. And then, of course, you can also go to kidsdata.org, as Reagan demonstrated, to find additional information and data about vaccine coverage and the burden of vaccine-preventable diseases in California, and specifically is broken down to more local areas. So on that note, I'd like to thank you for joining us here today. We're looking forward to the Q&A and further discussion during this webinar. And we also encourage further discussion on Twitter. So if you do plan to tweet about this topic or about this webinar, please use the handles that you see on the screen at PRB Data, at DataGeekB, and at Kids Data. Thank you.
Great. Thanks very much, Reshma. We actually had some questions that were submitted before the, pre-submitted before the webinar, and then a couple more that have come in. So the first one I think is maybe for you, Reshma, and that is, to what extent do social determinants of health adversely affect vaccination programs and therefore coverage?
Okay, thank you for that question, Mark. Yeah, this is actually a really great question, and one that we could talk about at length. There's quite a bit to discuss there. In short, I would say that social determinants definitely have an important effect on vaccine coverage, but in the interest of time, we'll kind of go through it briefly. Since this question was submitted ahead of time, we have pulled up a model that can help us kind of discuss this issue. So here, in the middle, we see SDOH, which means social determinants of health, and then it sort of points to a number of different factors that can affect health. So, for example, when it comes to vaccines, in orange, we see economic stability. And this can play an important role at all levels. So from the country level, economic stability is important when it comes to the ability to procure, to store, manage, and deliver needed vaccines. But it's also important at the family or the household level because even in many places where vaccines are provided for free, there can often be indirect costs associated with transport or missed work that are much harder for households with lower incomes to manage. Just to give another example, in blue, we see education as a key factor. And there are a number of studies in places such as India, Pakistan, Ethiopia, that show that increased levels of parental education in general, and also about vaccines in particular, are associated with higher rates of vaccination. And one thing to keep in mind is that maternal education in particular is really important. And it's been shown that interventions that couple vaccine-specific education for mothers, along with providing the social support networks, are particularly effective. And then finally, just kind of want to briefly talk about the bubble that we see in red, the neighborhood and the built environment. And that really speaks to the notion that where you live matters. And I think Beth kind of touched on this earlier when she discussed the pockets within countries, even where there might be higher coverage, that are more disadvantaged. And so we find that in these pockets, people who are living in communities that are poor, that are rural, isolated either geographically or socially, or which have weak or distant healthcare facilities, are really at a particular disadvantage. And it's also important to keep in mind when we think about neighborhood and the environment that there are populations like migrants or nomadic populations, refugees, who actually don't have a stable environment and or neighborhood, and so they really face special challenges when it comes to vaccination, especially when it comes to ensuring that children receive multiple doses of required vaccines. So I'm going to leave it there for the moment. We could talk about this at length, but I think that kind of gives an idea of how social determinants do play an important role when it comes to vaccine coverage.
Great. Question for Beth. In your opinion, does the organization of vaccination programs adequately respond to the current epidemiological, social, and economic, and political context?
I guess the short answer for that in some ways is probably not. If current programs were tailored to meet all of those challenges, epidemiological, social, and political, we probably wouldn't be having a conversation about world regions where coverage rates are below 75% or neighborhoods or regions within countries where coverage rates are below 50%. As noted throughout the presentation, particularly in some of Reshma's content, there are a variety of challenges to increasing global vaccination coverage. So, the current programs are trying, but not quite there yet. That said, there are lots of efforts underway to identify, understand, and overcome barriers to vaccination. So I do think that in many ways we've made a lot of progress globally in the last 20 years, and that there's still some work to do, but there's progress.
Okay. Are there particular regions, countries, or localities that should really be the focus of vaccination efforts?
Okay, thanks for that question. I think there are a couple of different sort of angles that we need to think about when we think about this kind of question. And one thing with vaccination to keep in mind is that we really have to maintain a continuous and a steady effort. Even where efforts have been successful in the past, each year we're dealing with a new set of children, and so it's almost like starting fresh, each and every year. And so we kind of need to stay on top of it and stay vigilant, and not to say, okay, well, we're doing well, so let's just think about other areas. So just to keep that in mind. But just still adding to that point, even though that's the case and that we need to stay on it wherever we are, it's quite interesting that there are actually some areas that could use some more focus and some additional attention. And as one starting point, there are actually 3 countries, and you can see in the graph that we've just pulled up here, 3 countries, India, Nigeria, and Pakistan, which account for half of the more than 20 million children who have incomplete DTP3 vaccination. So that's a pretty startling statistic. And this is due, in part to their large populations. Obviously, we know these are countries with with big populations, and it's also due in part to their lower vaccination rates. And then just adding to that, it's actually a total of 10 countries that account for nearly 70% of incompletely vaccinated children. So when we're thinking about where we might want to intensify our efforts or where we could get maybe say the biggest bang for our buck, these few countries could certainly use some additional attention and would be a great place to start. But I also do want to sort of remind us, and we've spoken about this at length, is that even in the US or in other countries where coverage is quite high, there are those pockets and those communities that are more disadvantaged and where vaccination coverage is lagging. So even if you're working within a particular state or a particular country context, and it's not that you're going to go now work in Nigeria all of a sudden, there are still pockets where you could focus attention, and these communities would really need that attention and those resources.
Okay. For Beth, what information can educators and health professionals provide to critics who might argue that vaccines are dangerous?
That's an excellent question, and one I think many practitioners struggle with. And obviously, lots of studies have suggested that just, increasing the vehemence of the argument that vaccines are important doesn't seem to work. And that while study after study has debunked rumors about vaccine risk, particularly debunking the autism vaccine link, I think it's important to acknowledge that any medical intervention does carry some risk, and that by not hearing parents' concerns that we may be doing a disservice to the messaging, because even over-the-counter medications like topical anesthetics and oral painkillers can be fatal under certain circumstances. So one key is for doctors and patients to have an informed and accurate conversation about relative risk. So to put it into context, the relative risk of death or disability from these diseases is far, far higher than the risk of death or disability from vaccinations. And communicating that message clearly is really important. Within the United States, there is what's called VAERS, the Vaccine Adverse Event Reporting System, where anyone, general public, medical practitioner, anyone, including non-medical professionals, can report any suspected adverse reaction that occurs after a vaccination. So there's a rich database of both cases that may have been vaccine-caused or cases where there's a suspicion or, an incident happened after a vaccine was administered. And these adverse events can range from low-grade fevers or pain at the injection site to things as serious as anaphylactic shock and death. But simply filing a report in VAERS doesn't mean that the vaccination caused the observed event, but it provides a useful benchmark. So if we look at the data from 2014, there were 9 confirmed pertussis deaths in the US in 2014, and the risk of death from pertussis is about 3 deaths per 10,000 cases. In the same year, using that VAERS system, so anyone can report, not necessarily confirmed, there were, and this during a year when millions of vaccinations were administered, there were 5 deaths reported in VAERS as occurring after a DTP vaccination. Again, those 5 were not confirmed as being caused by the vaccine, they just happened after the vaccine had been administered. But even if they had been caused by the vaccine, the risk of death from the vaccine is lower than 1 in a million. So in trying to get the message across to people that vaccinations are important, sort of the context is the risk of death from whooping cough is about 1 for every 3,000 to 4,000 cases. The risk of death from the vaccine is less than 1 in a million. If I were a betting person, I can tell you where I put my money, and getting that message across, that of course everything we do in life has a risk, but explaining what those relative risks are, I think, is really would go a long way toward allaying a lot of concerns.
Great. I guess 2 questions for you, Reagan. One is, does the kidsdata.org site have information on topics other than immunization? And then someone was curious about how you were able to get such robust data, I guess, for local areas on the immunization data for kindergartners. They wondered if the kindergarten immunization assessment captures all kindergartners enrolled in school, or is it based on a sample?
That's a very good question. So first, let me address the breadth of data that we have on kidsdata.org. So we have a variety of categories, and these address different categories of data. So, but some of them are more specific to kind of the social determinants of health. So we have child and youth safety, and this might include foster care and child abuse reported data. We have lots of information on children with special healthcare needs. We have demographic information, education and childcare information, emotional and behavioral health information, environmental health also as an important contributor to health, family economics, and then in the physical health categories where you'd find the immunization data. So the robustness of an individual data set really is unique to that data set. In the case of the children with all vaccine, kindergartners with all immunizations, all required immunizations data, that is from the individual school districts. And that information is compiled by the California Department of Education, and it filters up so that there is an administrative record at each individual school district for the numbers and then also the calculated percentages of all the kids in that school district who have all required immunization. So it's not a sample. It is all the children, but it does not include those who attend private schools. Actually, you know what, Beth may be able to better clarify that one. But from my understanding, I believe it's the collected at a school district level, and I believe it's public schools only. Am I right on that,
Yeah,
Beth?
that's correct. There may be some private schools that report to the state, but because private school reporting is not as consistent, the data on kidsdata.org is all public schools and public school children.
Okay, there's a question, how is it that West Virginia has substandard MCV rates, given that they have very stringent state immunization regulations? I think it's West Virginia and Mississippi maybe that have no personal or religious exemptions for those requirements.
And I'm going to scroll back up to the map to answer this question so we sort of see what the Inquirer, or for DTP coverage, West Virginia is not doing so badly, but for, I think this person may be referring to the MMR coverage. Yes. And the only explanation I can think of is that we're talking about slightly different populations. So the data that you see on the screen here is from the National Immunization Survey, and this is a survey of very young children aged 19 to 35 months, so about 1.5 years to about 3 years old. And the survey targets that group because it's the age at which that series of vaccinations should have been completed, and it's also a population that's young children are the most susceptible to diseases like measles and mumps, rubella, and pertussis. So that's why the survey focuses on those on that age group. When we talk about state policies related to immunization prior to enrollment in school, that doesn't usually kick in until kindergarten age. And so what may be going on in West Virginia is there may be a delay. So children may be getting the vaccinations at a later age. And so it's the difference in populations is probably why there's a difference between what we see on this map with coverage for young children and what you would expect to see based on the policies in that state.
Okay. Just a couple final questions. One is someone was curious about getting some more details about the sampling techniques that were used to collect these data. I assume they mean for the United States. Do you have any of that information handy?
For the United States data, the by state information is from the U.S. Centers for Disease Control and Prevention and their National Immunization Survey, and I would refer the Inquirer to the CDC website, which has all of the data on methodology for the data that they collect.
Okay. And then finally, is there any strategy in place to achieve the targets that have been set for the Millennium development goals globally, especially for developing countries. And I guess they mean the development goals related to immunization coverage.
Right. Well, if you recall earlier, I did mention the Global Vaccine Action Plan. And within that plan, it does lay out, as I mentioned, it laid out a number of broader sort of principles and things that need to be looked at. But then it also goes into a few more details in terms of specific activities. So looking at that plan could sort of give you a much better idea of the specifics in terms of what's planned for that. But much of it does include what I mentioned sort of in that last slide about moving forward.
Well, that's it for the questions. So for all the participants, I would encourage you to go take a look at the article on PRB's website, www.prb.org. That's an article that Beth and Reshma wrote about all of these issues. And then to visit the kidsdata.org website for California data, which is also compared to the U.S. I mean, California has sort of been ground zero for a lot of these discussions, so it's a great place to look at what's been happening over the past several years. And with that, I want to thank all of our presenters for taking the time to present today. It's certainly an important topic and timely, given the recent developments in coverage and policy changes. I also want to thank all of our participants. So thanks, everybody.